The broadcast is now starting. All attendees are in listen-only mode.
Good morning. Welcome to the KHC monthly webinar brought to you by your friends and colleagues at the Kansas Healthcare Collaborative and in partnership with the Kansas Medical Society and Kansas Hospital Association. Today is Wednesday, July 22nd, 2020, the fourth Wednesday of the month, which is our usual webinar day. My name is Michelle Clark, a program director for KHC, and I will serve as your facilitator today. A focus in patient safety for healthcare providers in nearly all settings is reducing adverse drug events and opioid misuse. We're glad you could join us this morning as we learn together about KTRACS, Kansas's prescription drug monitoring program. KTRACS helps improve patient care, safety, education, and outcomes through detection, prevention, and intervention, while preserving access for patients with legitimate medical needs. This event is being recorded and will be available online in our KHC Education Archive in the next day or two. And I want to introduce some of our features of our new webinar platform, GoToWebinar. At the top of your attendee control panel are options for listening to the audio portion of this virtual event. While most individuals listen through your computer audio, you also have the option to dial in. So by clicking on the phone call option, the dial-in number is shown along with the access code and PIN. So be sure to enter your PIN in the event we might have an opportunity to open your line later for a question. And for this event, everyone is automatically muted except for our speakers, and we also have the option to open audio lines as needed. So let's practice with the hand raising tool. If you'll see that on your screen, if this is your first time to join KHC for its monthly webinar, please raise your hand. I believe we have a few new guests joining us today, and welcome to everyone. Okay, and the next item on your control panel is a module providing handouts for this event. Please click to download the presentation handout if you don't have it yet. The PDF also includes convenient links to many of the upcoming events we'll share at the final portion of our program. And then most importantly, please use this questions or comments pod. This is a feature that you can ask questions of our presenters, and we'll pause from time to time to address any questions or to share your comments that way. And we also have a few polling questions for you, so please be ready to respond with your computer, mouse, and keyboard. And for our introductions, we're very pleased to introduce our guest presenters from the Kansas State Board of Pharmacy. Alexandra Blais is Executive Director of the State Board of Pharmacy. She is a JD Juris Doctorate and MBA graduate of Washburn University in Topeka, Kansas, where she also earned undergraduate degrees in business and in vocal music performance. She's an attorney licensed in the state of Kansas and worked for the state in such capacity for several years before joining the Kansas State Board of Pharmacy in November of 2015. We also have with us Jennifer Donnelly. She is Assistant Director for KTRACS. She has been with the State Board of Pharmacy since January 2019. She has a master's degree in public health with an emphasis in epidemiology from the University of Colorado. Jennifer is a senior epidemiologist at the Board of Pharmacy and helps to direct the KTRACS program. And we have with us Reyne Kenton, who is Program Manager for KTRACS. She has been in this position for 4 years. She received a BA from St. Mary of the Plains College in Dodge City, Kansas. She is a CLEAR Certified Inspector Investigator and is commissioned by the FDA. She also served on the PMIX Executive Committee for 3 years and the APRIS Advisory Committee for 2 years. In 2017, Reyne created the PMP Administrators Roundtable, attended by 32 states and held in Overland Park, Kansas. And then we also welcome Allison DeGroff, KHC Executive Director, and in a few minutes, Allison will be sharing with us a few updates and help kick off our featured topic. I also want to thank my colleagues Rhonda Lassiter and Phil Coffin for their support in the conduct of today's session. Rhonda will help keep an eye out for your questions, and Phil will be assisting us with our polling questions. And we also appreciate KCO Day with support with our GoToWebinar. All right, our agenda is fairly straightforward. Following Allison's opening remarks, we will dive right into our featured topic, KTRACS, Clinical Decision Making at Your Fingertips. Alexandra, Jennifer, and Reyne will share an overview of Kansas prescription opioid dispensation data, as well as an introduction to the KTRACS program and its many features. We'll wrap up with a wealth of educational resources. And at the end of our program, we also ask that you take a moment to provide your insights and feedback to this virtual event. So let's hear from you and who is in our virtual meeting room in our poll number 1. Phil, will you please open our first poll? And please take a moment to let us know whether you are joining us from a hospital with 25 or fewer beds, with a clinic or in an ambulatory setting, a hospital with more than 25 beds, or perhaps you're with an affiliated partnership organization or another organization. So select the best choice for your organization. All right. So thank you very much. Let's close the poll, Phil, and let's see who we have in the room with us. All right, looks like we have a large number of folks with 25 beds or less, and the larger hospitals are next, and a nice turnout from clinic and ambulatory setting, and then other organizations. So thank you all. Thank you for joining. All right, I am now pleased to turn the program over to KHC Executive Director, Allison DeGroff. Allison?
Oh, thank you, Michelle, and good morning to all of you. It is a gorgeous day up here in the northeast portion of the state, and the sun is shining, and after a lot of really good rain yesterday, at least up here, it just kind of feels like a fresh and perfect summer day. So we appreciate your taking a little bit of time out to join us for this webinar. I know that just looking at the poll question, giving us a sense of where everybody's from. These webinars originally were part of the HIN program, and when many of you are probably familiar with that, hospital-based quality improvement project that KHC was involved in for about 8 years. And when that program concluded at the end of March earlier this year, we made a decision organizationally that we felt like these webinars were very important to continue. And we now have not only folks from the hospital community represented on these webinars, but we have a growing number of representatives from physician offices and clinics in the ambulatory setting. And we're very excited about the calendar that we have in development for the balance of the coming year, looking to provide all of you education and clear, meaningful resources on priorities in patient safety and quality improvement. If you had the chance to join us last month, we talked a little bit about some of the federally driven quality improvement programs that are on the horizon, and just wanted to give you all an update on a couple of those. Those of you who are engaged already in HQIN, which is the quality improvement organization work that we are partnering with a company out of Virginia to do here in our state. KHC is excited to be a part of the community coalition aspect of that that program itself, and we are still in the recruitment phase for that. It is going to be an initiative that allows both hospitals and clinics to partner with other organizations in the community, in your own community, to identify how to make meaningful progress on needs for your own community. And KHC will be providing resources to help make that happen, be providing support for learning opportunities. And those of you who have participated in some of those programs before, you'll have the opportunity to work with some of the same key staff that you did when you participated in the PTN or the HIN. So that we hope that you will, if you haven't already signed up for that project, it's free to you, free resources. And so we hope that you'll reach out to us here at KHC for more information about that. We also are looking forward, hopefully in the next 60 days or so, to hear about the initiation of the clinician-based improvement work that will be the second iteration, if you will, of the PTN. And I know that many clinics here represented on the call participated in the PTN. So that project is called See Quick, and it is going to, we hope, get kicked off later this fall. And we also know that hopefully the next iteration of the HIN, which is called H Quick. You're probably seeing a theme here of the quicks, but we hope that the H Quick will also be kicked off later this fall. And that one of the unique aspects of all of these federal programs is that the work is aligned around a common set of aims and priorities. And obviously the interventions differ based on the setting in which the care is being provided, but the aims are the same. And one of those aims, obviously, it goes without saying that pandemic response is going to be a part of all of this work, as it will be in probably nearly everything that we do going forward, all of you do going forward as you're providing care to patients every day. And we are, we're cognizant that before kind of the pandemic took the air out of everything in all of the healthcare worlds, especially, that there was and is a serious opioid epidemic in this nation. And there have been a lot of meaningful efforts on here in Kansas that you're going to hear about from Alexandra and her team. The healthcare community really supported the development of K-Trax and believes it is a meaningful resource. In fact, the American Medical Association just released officially this morning their 4th annual report from their opioid task force, and that information is actually at a specific website that we'll be sure that we add to the resources here that you all can access. But one of the telling aspects of this is that while the pandemic has gone on, there is no doubt that the opioid epidemic has grown more deadly. And it is impacting many people across this nation and here in our state. And that epidemic is being fueled by illicit fentanyl, by methamphetamines and cocaine and heroin, and not as seriously fueled by prescription opioids as it has been in the past. And K-Trax is an absolutely incredible resource for all of you who are providing direct patient care every day. It's interesting, the AMA's data illustrated that in Kansas in 2017, there were 856,000 or about 857,000 queries to K-Trax. And just 2 years later, in 2019, K-Trax reported that there were more than 14 million. So to say that this is a meaningful resource, that data alone illustrates how important it is for us to find ways to meaningfully incorporate accessing the prescription drug monitoring program data into our regular routine of providing patient care. And I am pleased that we have the K-Trax team here to to tell us more about the program. And what I would like to do is go ahead and just hand it off to Alexandra with a warm welcome. I know she's very familiar with the collaborative and the family of companies here at the Medical Society and CAMCO and the Hospital Association. So Alexandra, thanks for being here, and I'll hand it off to you.
Thank you so much, Allison, and thank you, Michelle, as well, for that fantastic introduction. We're so thrilled to be here today with you to talk about KTRACS and what it can mean for you in your practice and your day-to-day work, as well as some of the really interesting overarching highlights of what we've learned over the years about the data that's being submitted to KTRACS and some of the good trends and maybe not so good trends that we've seen with this data. And I am the Executive Secretary of the Board of Pharmacy, which is home to the Kansas Prescription Drug Monitoring Program. Jennifer Donnelly is our Assistant Director and Senior Epidemiologist, and then Reyne is one of several members of her team, and she deals with the day-to-day program management of our fantastic program that needs great attention. Let's go to the next slide. So just to give you a little highlight of the objectives for today's presentation, we are going to talk about just what the KTRACS program is, give you a little bit of a brief overview if this is the first time you've heard of it or maybe you're not as familiar. We also want to give you some information about who uses the program and how you can register for it or how a delegate can register, as well as the use and benefits of participating in the KTRACS program on a more regular basis. We'll talk with you about the evolution of where KTRACS has come from and how it is now integrated actually into electronic health records and pharmacy practice management software products, about our prescriber e-recap report, which we affectionately call our PERCS report that prescribers can get on a quarterly basis. Jennifer is going to talk with you a little bit about all of the data that we are seeing with KTRACS and what the meaning is behind some of those data points and statistical analyses. And then I will finish up with some of our proposed legislation changes that we are hoping to bring to the legislature this coming session and continue that evolution of the program. Next slide, please. So KTRACS really falls into three broad categories here of implementation, investigation, and education. To give you kind of a little bit of background, KTRACS is a database really at its core. It was implemented by the legislature in 2008 and really became fully operational in late 2010, early 2011, collecting the data. It was kind of an abstract concept at the time. Not many states even had a prescription drug monitoring program. And Kansas was really on the forefront of being one of the states that was quick to act and implement software to begin collecting prescription drug information. So KTRACS actually collects controlled substances 2, 3, and 4 in the Scheduled Controlled Substances Act in Kansas, as well as a series of drugs of concern that are adopted by the board by rule and regulation. And prescribers are not required to use the system, but it's a voluntary system. However, pharmacies are required to submit data each day for all of the prescriptions for those controlled substances that are dispensed on an outpatient basis. And that includes anyone with a Kansas address of record. So if you receive that prescription at a Kansas pharmacy or a pharmacy from anywhere in the US dispenses that prescription to a Kansas address, then we are collecting that data in our system. So it's quite robust. And it serves an important purpose in bridging the gap of some of the information that one health system may have or another health system may have, or pharmacy management systems. And Reyne manages our system administration as well as our vendor, Apris Health. And we provide user support for individuals and prescribers and dispensers and their delegates that want to get registered in the system. And then we've also evolved the program to actually incorporate that data on a user-friendly basis right into the electronic health record. We have also begun working on our data quality initiative to ensure that the data that's being reported into our system is incredibly accurate and there aren't any gaps of data or missing information that pharmacies may have missed in terms of reporting. And if you think about that, it's a little bit confusing, why would there be information that's missing? Well, in each state, controlled substances can vary and be different, as well as our list of drugs of concern. So with national pharmacy chains and things like that, we just want to make sure that everyone is aware of what data has to be submitted and ensure that the data that's being submitted is both timely and accurate. On the investigation side, this is really where we get into the core mission of what KTRACS is. So KTRACS was designed with the mission of preventing the misuse, abuse, and diversion of controlled substances and drugs of concern, but ensuring continued availability for patients for legitimate medical use. And that is a very important balancing act. But on the prevention side, we really have to look at some of the data that we have and put that to our prescriber and pharmacist advisory committee that oversees KTRACS and provides guidance for our day-to-day program to make sure that there aren't any potential bad actors or patterns of concern that may be identified where investigation may be necessary by the appropriate regulatory authorities. And the KTRACS Advisory Committee is actually the only body vested with that authority in the state of Kansas. On the investigation side, of course, obviously, we want folks to implement best practices, and then we do our epidemiological analysis that Jennifer is going to talk to you a little bit about the fruits of that labor in a little bit. And of course, education, which is perhaps the most important component here. It's what we're doing today. It's why we're here, and it's what propels the program forward. Our public information officer is working on starting some campaigns and implementing some improvements to our website to help increase our level of awareness, not just among prescribers and dispensers, but also among members of the public, because we think it is equally important that an average individual or a patient is aware of the Kansas Prescription Drug Monitoring Program and understands its function and its impact, not just to deter potential shoppers, but also to make sure that people understand how their personal health information is being managed and used and secured by our office. So KTRACS is a 24/7 web-enabled database. It is highly secure and meets all regular HIPAA and other patient data privacy security requirements. And that's why we use Apris Health. They're a fantastic vendor in that capacity. But it's really important that everyone understand how seriously we take the information that we're being given at the Board of Pharmacy. So with that, I will let us go on to the next slide and turn it over to Reyne.
Hello, everyone. Thank you for having us. It looks like we've got a poll question. If you guys would, if Michelle, would you like to do that one?
Okay, we have the poll open, so if everyone will respond or let us know whether your facility has procedures in place for checking KTRACS when controlled substance is prescribed. And the options are yes, no, or unsure. Okay. Phil, whenever you feel like we have enough of a response, just close it. Okay. Phil, would you be able to read out what the responses were, please?
Looks like we have 50% saying yes, 8% saying no, and 42% unsure.
Thank you very much. Back to you, Reyne.
That looks great. Thank you. Next slide, please. Why to use K-Trax? You know, K-Trax will help with clinical making decisions on the provider's part. It does help prevent misuse, abuse, and diversion. I realize most of those in your field understand what misuse and abuse and diversion are, but when I speak to the public, I like to tell them, you know, misuse is when you use a prescription. Say a doctor has given you a Percocet when you had surgery, and you decide at some point that you have saved those and would like to use them, take them to sleep better. That is misuse. Abuse is when you use too much of a medication, and diversion, of course, is basically a word for theft. K-Trax helps identify patients for the assessment and treatment of political substance use abuse and disorder. We really stress, and I love the 50% of the fact that your clinics and the people you work with do have you use it. I love that. This program can save lives. Next, please. To register with K-Trax, the email address given is where you go to register. If you have any questions, please do not hesitate to call me or text me, email me. Basically, the things to remember is this system does time out. If you think you can't finish and don't have all the information, please hit the continue and for later button, which we've recently added, which will help you and I both a lot. To prepare for registration, if you are a provider, you will need your state license, your MPI number, and your DEA number. Please note that incorrect registrations will be rejected after 1 week. And the reason we do this, if it's not complete or there's some misinformation, the system has a security measure. Well, it will trap that email. Now, if you work at a small Western Kansas clinic, that's one thing. But if you work at KU Med or if you work for an Ascension, it's kind of difficult to get a new email address. So we try to get in and get those out of the system before they can trap. But this way, all you have to do is go back in and put the information in again, and just remember that you have a week. Next, please. Okay, and I'll turn back over to you, Michelle.
Okay, our next polling question is, let us know your response to this statement. Phil, if you'll open up the poll. Our prescribers use delegates to streamline their workflow and increase their usage of K-Trax. So the responses are yes, no, or unsure. So if you would, select the best answer for that. And Phil, if you'll let us know, give it a minute and then let us know how the poll turns out. All right, let's go 3, 2, 1, and let's close and see how our responses are.
Okay, it looks like 23% say yes, 19% no, and 57% unsure.
Thank you, Phil.
Thank you, Phil. Thank you, Michelle. That helps a lot. Thank you. Next slide, please. This is basically, if they are interested in having delegates, this is basically you go to the same address the delegate goes to the same address to enroll. Delegates must use their work email address. Delegates must have their supervisor's DEA and the email address the provider used when registering. Once the delegate has submitted all information, the supervising prescriber or provider will receive an email to approve that individual. Currently, the delegates that we are accepting are RNs, LPNs, and pharmacy technicians. Also, as a provider, if your delegate resigns or is terminated, please give us a call at the office or email us at that email so that we can get them out of the system and they no longer have access, especially if they have access under your account. Next, please. This gives you an idea of a breakdown of what it looks like of who is enrolled in KTRACS. As you can see, we've had a 77.9% increase from 2015 to 2020. The major part of our prescribers are the major part of our registered KTRACS users are prescribers, and you can see the blue is the pharmacists, and then the yellow are the delegates. We're very happy of the increase and the usage of this great program. Next, please. We have started the statewide integration, which we are extremely proud of. It is a project that we are doing with KDHE through money granted from the CDC. Basically, we integrate directly into the health electronic health records or the pharmacy provider. As you can see, it improves access. One of the complaints about KTRACS from providers was that it was so slow. They had to go in and out of the system to get in and out of their pharmacy system or their EHR to get to the portal and then back. This on the average will save 4 minutes per transaction, which in an ER is a huge amount of savings on time. As of September 2019, we had 794 integrated. I will say I tried to get a percentage together of how many we have of clinics and how many we have of hospitals. I could not do that on the information that I have, but I do have a call into my vendor, Apris Health, to see if they can give me a better idea. And then I will share that information with Michelle. Next, please. This kind of gives you an idea of the most common and important problems that we address with the statewide integration. You don't have the username password error because you use the password and the username you use when you log on to your EHR. There is I think the most important is the interruption of workflow. Everything works so much smoother with this. And there is no lost clinical time. So we like to promote this as a time-saving, money-saving. Basically, the state pays for the information to cross across what we call the gateway, which is owned by our vendor, Apris Health. And that is how the information goes from the KTRACS website to your EHR. Next, please. This gives you a quick view of the integration sites in the state of Kansas. You can see it covers the whole state. Of course, the largest percentage of dots are in the Wichita area, the Kansas City area, and then a larger amount here in the Topeka area. But as you can see, it goes clear out to the Colorado line, the Nebraska line, and covers the Missouri and the Oklahoma. So we're very proud of how far this has gone and how many hospitals and clinics and pharmacies are participating. Next, please. This is something we started, perks that we started with a BJA grant, which is a division of the Department of Justice. Basically, it's a snapshot of the prescribers' prescribing practices. It is released quarterly, but the numbers actually cover the prior 6 months. It shows how many patients you have on opioids and compares you to the others in your specialty. It talks about it shows the MME ranges, the opioid treatment duration. And what I really like to show people is it tells how many multiple provider episodes, AKA drug shoppers, however, you categorize those that you have, the possible ones you could have. Also, it shows the dangerous combination of therapies, benzos and opioid combinations. Next slide, please.
Renee, I goofed up a little bit. This polling question should have been earlier. Let's come back to the polling question after this next slide. All right.
Not a problem. Okay. This is actually what the the PERCS report looks like. As you can see, it basically gives you all of the graphs that shows you how you compare to others. What I really like to show is the bottom part of it. It shows how many times you or your delegate have queried the system. It shows how many patients you have that possibly could be getting that combination of opioids and benzos. It just is a great reference point. Now, I do want to say these are for the provider's eyes only. We do not share these with the hospitals or the clinics. These are for the providers only. Next slide, please.
Okay, Renee, you want to go back to the polling question now?
Perfect, thank you.
All right, so this relates to the electronic medical record integration. So polling question number 4 is, Phil, if you'll go ahead and open it up. Our facility integrated our electronic medical record and or pharmacy system with KTRAX. So yes or no or unsure. So the poll is open. And we'll count down from 5, and then we'll see the results. 5, 4, 3, 2, 1. Go ahead, Bill.
Okay, it looks like we have, excuse me, 37% yes, 17% no, and 46% unsure.
Well,
Right.
I like that top number. That's fabulous. Okay, and I will now turn this over to Jennifer Donnelly, whose expertise I so appreciate. Thank you for having us.
Good morning, everybody. This is Jennifer, and I'm just going to go over a few slides that discuss the data. Of course, our presentation wouldn't be complete without the data, and it's one of my favorite things to talk about, of course, being from the public health epidemiology side of things. So the graph that you can see here is the total controlled substance prescriptions that we have in KTRAX, and these are only Kansas prescribers and Kansas dispensers. And you can see over time that we've had an 8.5% decrease from 2017 to 2019 in total dispensations. And for the current first half of 2020 compared to the same time period for 2019, we've had a 6.4% fewer controlled substances prescribed in Kansas. So whether or not, we can't really say that this is attributed to KTRAX or prevention efforts or education that has been done by the Centers for Disease Control or other federal agencies towards prescribers or dispensers. But what we can see is that probably all of those things are having an effect on how prescriptions for opioids and other controlled substances are being written and checked within our state. You can see that 2017 was sort of a peak for us in this 5 years look at data, and things are trending downward. So that's really good news. Next slide, please. One of the things that KTRAX really strives to look at, as Alexandra sort of alluded to in the beginning of the presentation, is the investigation piece. We really want to make sure that high-risk patient prescribing is something that we very carefully investigate. We also look at what's called doctor shopping behaviors, and we want to really sort of curb those things, because that indicates to us that there is misuse or abuse of prescription drugs, controlled substances occurring across the state. So one of the things that you can see is that as patient queries, which is denoted in the blue section of the graphic, as patient queries have gone up, so queries by providers and dispensers utilizing KTRAX the way that it's supposed to be used to monitor prescribing habits and what patients are getting, doctor shopping behavior has gone down. That's the yellow line, and we know that there has been a almost 50% decrease in doctor shopping behaviors among patients for the past 2 years. And it has sort of stabilized in 2019, but that 50% decrease in the past 2 years is really one of the things that we attribute to the investigation piece that we've done at the Board of Pharmacy and at KTRACS with the assistance of our KTRACS Advisory Committee. So really looking at those patients that are showing possible strange use or a red flag type of use of controlled substances, and really diving deeper into that investigation to make sure that we can reach out to prescribers or patients or law enforcement to stop that type of behavior. Next slide, please. I also just wanted to kind of go through the age-adjusted mortality or death rate in the state of Kansas per 100,000 population. You hear a lot how the opioid crisis across the United States is really impacting people and the death rate. And what we found is that actually in 2016, 2017, we saw an increase in the, or actually, I'm sorry, a decrease in the number of the years of life expectancy in the United States. And some people really attribute that to the opioid crisis in part. But what we can see in Kansas is that we've had a peak in 2013 and 2014, and then we've slowly gone down in terms of the mortality rate that is attributed to prescription opioids. It is noteworthy to see that women tend to have a higher rate of mortality due to prescription drugs than men. But this may be because women tend to seek out care more so than men, so they may have higher prescribing rates. In KTRACS, we can monitor use between males and females. It's not something that we've done routinely, but it's something that we plan to do as part of a data dashboard that will be able to be viewed on our Prevent Overdose KS.org website that is in conjunction with the Department of Health and Environment. Next slide, please. So with this, I will hand it back over to Alexandra and just thank everybody for the opportunity to talk about KTRACS with you today.
Thanks, Jennifer. So we are constantly trying to move the needle forward on our KTRACS program to help continue to slow the spread of any kind of continued illicit use of prescription controlled substances. And it is, I think, noteworthy to talk about the opioid epidemic. It certainly has not left us, even during that time of pandemic. And despite the global awareness to this issue in our current state of mind. However, there are still other controlled substances that have proven to be concerning, and we're constantly trying to stay on top of what that next thing is. And in Kansas, one of the things that we've found noteworthy is the issue with stimulants and as Reyne was talking about, the dangerous combination of therapies, especially when one prescriber is not aware of another prescriber interacting with a patient and prescribing that potentially dangerous combination. And so that's why the KTRACS program sort of fills that gap and provides that information. But a few of the initiatives that we have been pursuing recently have included some updates to the actual Prescription Monitoring Program Act in the state of Kansas. And we have collected information from our stakeholders and many of the partners that have been mentioned already today, as well as the Kansas legislature and the KTRACS Advisory Committee, to identify a few areas where improvements can be made. And so one of them is an actual statutory definition of delegate. And that's important not only because we interact with other states and share data back and forth with other states for prescribers and dispensers to utilize, and we want to have clear definitions of the different roles that states allow, but we also want to have clarity in terms of who can access this highly sensitive data. And as I mentioned at the beginning of the presentation, we want to make sure that we're being good stewards of the data and providing access to appropriate individuals. That includes all prescribers and dispensers, which are very clearly defined by law, but are not necessarily defining what a delegate is. And so we've been using internal policies and procedures for many years, but we think it's important to include that in a statutory context to really protect the data. We also want to begin to allow de-identified data to be used for additional research purposes. Right now, we're able to do that for aggregate level data, but unfortunately, there are some research projects that have been presented to us over the past 5 years or so that we have really not been able to share, unfortunately, because of some limits in the way that the Act was outlined. So to give you a perfect example, we have clinicians that reach out to us on a regular basis that want to go through the IRB and put together a research project with patient consent and all of those things to actually research patient utilization of opioids and weaning off of opioids and some other things. Unfortunately, because those patients are identifiable, even if they consent to the release of their KTRACS information, we're not able to provide it for the purpose of research. We're only able to provide it for the purpose of clinical care. So, we've identified some areas where with the appropriate protections, IRB approval, patient consent, et cetera, we would be able to actually even allow the potential for identifiable data in certain circumstances to be used for research purposes. We also currently have a 5-year limit for data retention and storage. And as you can see, Jennifer's done a lot of great work with the information and data that we do have. But we're getting to the point where we realize there are opportunities for further evaluation if we could retain data for longer than that 5-year period of time. And so we'd like to pursue that for mainly the purposes of research and in informatics. But we think there are some other opportunities there as well that would not limit the 5-year mark. And then we would like to begin expanding the program a little bit, as we've seen some other states do successfully, to allow the collection and addition of some additional PDMP components in our KTRACS system, which we would partner with some of our other state organizations to compile. The top two are very important: date of death and fact of death. We think this is imperative because in KTRACS right now, there is no way of identifying if a patient that you are looking to prescribe or dispense to is still alive or deceased. And for instances where people might be abusing an identifiable document or attempting to elude authorities, we think it's pretty imperative that we be able to identify in KTRACS whether or not a patient has been deceased. So that date and fact of their death would be critical in identifying whether or not a prescription should be issued to a patient. We also are pursuing the ability to include clinical notes. This would be an opportunity for prescribers to utilize a field to include some brief notes about whether or not a patient has perhaps signed a patient pain contract, or they have decided that they don't want to be prescribed certain medications for whatever reason. That information would be able to be included. If a patient potentially has suffered a drug overdose in the past, those are the kinds of things we would want to have included. Some have expressed concern about the potential inclusion of some of this information, and we want to make sure that that is heard and responded to. So obviously it would be inappropriate for KTRACS users to include anything that would be inappropriate about a patient. And other states have gone down this road and identified, I think, some clarity around how those clinical notes can be confined to the appropriate documentation for KTRACS as opposed to some other type of medical record. Overdose events I mentioned, and then the additional piece that we have really brought on in the last 2.5 years is naloxone dispensing and administration data. Kansas was able to procure a statewide a protocol for dispensing of naloxone pursuant to a statewide protocol signed by Dr. Greg Lakin. And so pharmacists are able to do that for a patient, a bystander, nurse, school nurse, or even a law enforcement agent through the pharmacy by that statewide protocol without an actual prescription for the naloxone. And so as that's becoming a little bit more commonplace now, and people are carrying and utilizing naloxone as an opioid antagonist, we think it's important that we begin to collect some of the information about this. The Board of Emergency Medical Services has been collecting data on EMS administration of naloxone for some time, but the KTRACS Advisory Committee has expressed a lot of interest in understanding how widespread the naloxone component is. And it could be that this is information that we ultimately collect in the system and don't display to others, because it may not be very informative if a family member or friend receives a naloxone prescription or dispensing, but it's actually not for themselves. It doesn't really inform the situation. It may be for someone else, and we're aware of that. So these are just some items that we are pursuing and trying to continue to improve the data collection and availability of information that's available to our KTRACS users to help better inform and be consistent with our mission of preventing while continuing to ensure legitimate medical use. So I think we've left you with quite a bit there. And with that, maybe I'll ask Rhonda if there are any questions so far that we can answer.
Alexandra, I do see one question. This is from Erica Fortin. Erica would like to know, do you see in the future expanding the monitoring beyond Kansas? She says, we are 15 miles from the Nebraska border and several patients cross the state lines.
That's a great question. We are part of the prescription monitoring program Interconnect system. And so we actually share data with, I believe at last count, 36 other states. And so that is a two-way street of data sharing back and forth. Missouri and Oklahoma are included. I believe Colorado is as well. And we are also connected to the RX Check Hub for interstate data sharing, which is actually the federal program. And we share, I believe, with at least one other state on that program. It's far less used. Unfortunately, Nebraska is not connected to the PMPI, and so we have not yet connected with their system. There are some inherent challenges with Nebraska since their prescription monitoring program is actually collecting all prescription medications, not just controlled substances. And so I am not aware of how many states Nebraska is sharing with, but they have not been doing, or their PDMP has not been operational for as long as ours has. And so we hope to connect with them at some point. I believe we have a one-way connection with them on the RX Check Hub, but that is something we're very cognizant of, especially being in the middle of the country where folks do travel state to state. And it is, especially for doctor shoppers, it is easy to cross state boundaries and seek prescriptions in multiple states with the prescribers and dispensers none the wiser. But the nice thing is that we have, so with our base level KTRACS program, we are connected to 36 states. And then we are also trying to continue to add states for the interstate data sharing connection through our gateway electronic health records system. So about 2 years ago, when we started the utilization of the integration into the EHR platforms, unfortunately, you lost that interstate data sharing piece. Now we are beginning to see it added back in by states that have identified that that's a gap, again, unfortunately, that we had previously filled and now it doesn't exist. So we're working on that, and yes, we do hope to be able to be connected to all the states in the Midwest, as well as the states that would be frequent traveler states or snowbird states.
All right. Alexandra, thank you very much. This is Michelle. I believe we don't see any other questions in the submitted so far. We have 5 minutes left. Any final words?
Well, I just want to thank everyone for their time today. And of course, I would be remiss if I didn't acknowledge our KTRACS Advisory Board, which I believe both the Medical Society and we work with the Hospital Association as well, with our stakeholders to make sure that the guidance for the future of the KTRACS program is consistent with our mission and what prescribers and pharmacists actually use within the system. So that's very important. And then I always want to thank our KDHE partners, Ann Ella Fritz, Adrienne Harrell, and Julia Baumann. The Kansas Department of Health and Environment has been a tremendous partner in procuring millions, literally millions of dollars in federal grant funding that we have partnered with them on improving the program, and the entire integration funding is thanks to that partnership. So they've been fantastic, and we're very, very lucky to have such a great partnership program and stakeholder program for KTRACS, and it is only through those individuals that we're able to make it so successful.
Awesome. Well, thank you so much. And I know there are probably lots of questions out there. I know, just in the interest of time, you do have contact information for Alexandra, Reyne, and Jennifer. So please reach out to them if you have any other questions around KTRACS, or who to contact for EHR implementation, or what some opportunities might be for better utilization of KTRACS in your setting. So thank you all very, very much for sharing this great information with us today. Okay, well, let's move on to the resources and upcoming events. And I wanted to share with you a little picture from the sunflower field around the corner from my house. That's in Berryton, Kansas. It's sunflower season, I'm just loving it. Just a few quick resources. The next few slides are just rich in some wonderful free learning opportunities. So I hope you guys will share this information with others in your organization who might benefit from these. I want to start out with the 2020 Kansas Opioid Conference. It will be virtual this year, and there is the call for presentation proposals is now open. So if you have something that you would like to share and present at the Kansas Opioid Conference, your presentation proposal will be accepted through August 31st. So we hope you will consider that. And then registration will open in mid-September for the event that will be online November 12th and 13th this year. And then we also want to share the U.S. Department of Health and Human Services, or HHS, is offering virtual peer-to-peer learning community called Telemedicine Hack. It's a 10-week series that will provide you with knowledge and skills you may need to implement video-based telemedicine in your practice. So be sure to click on the link and learn more about that offer. And then another resource that is free, this is just an amazing weekly learning curriculum, but I know many of you in the audience are affiliated with nursing home, long-term care, or have colleagues in that setting. So please share the information of the CMS hosting a weekly webinar series through its Quality Improvement Organization program to provide free training for infection control processes in nursing homes. So I think they've had 2 or 3 sessions so far. The next session is tomorrow from 3 to 4 Central Time. And then you can sign up for all or some of the sessions. So the link is provided there. And then through the HQuinn, there's a similar topic. Office hours for nursing homes are 3 dates to be infection control survey ready. And there's a link to register for each of those sessions. And another event coming up on July 30th is Integrating Behavioral Health to Improve Patient Outcomes. And there's a link to register for that. And another free e-learning program is with the U.S. Department of Health and Human Services Office of Minority Health. We've talked a lot about cultural competency, but this will be for behavioral health professionals. And so to learn how to better respect and respond to your client's unique needs, there's an online training with CEUs available, contact hours available for certain professions. And then for the Kansas Hospital Association, COVID-19 clinical calls are occurring from noon to 1 p.m. The next one will be July 28th, focusing on pediatrics as we go back to school. August 11th, testing and treatment modalities. And then the third one on the list is August 25th. So to receive the connection information and join the distribution list, the link is provided. And wrapping up, the next QHI training session will be Thursday, July 23rd. So that will be tomorrow at 1:30. And we'll have a demonstration of the newly designed data submission page and walk through reporting opportunities as well as reviewing the basics. So please register for that if you'd like to learn more about QHI. And then another question we've had is how to register for KHC events. Our registration is open for our next event on August 26th and other events that KHC is associated with. We have the dates for the rest of the year posted, and we will be announcing the topics for those soon. We also have an education archive where our recordings are posted, so we invite you to check out those resources if you're working on anything particular, such as fall prevention, hand hygiene, readmissions, etc. And we'll be building on those as we move forward in our work. And then KHC does have a monthly newsletter. We encourage you to sign up to receive it if you're not already on our email distribution list, so that there's a link where you can sign up for the newsletter. And then follow KHC on social media. And we have some samples of some of our, how to find us and some samples of some of our posts. So we'll check. Rhonda, do we have any other questions from our participants?
I see no more questions, Michelle.
Okay, well, I'm going to put the link in the chat for your feedback for today's session. And if you have any other questions, you can add those in there too. We'll share them with our KTRACS team, State Board of Pharmacy. And thank you all very much for joining us today. It's always an honor and a privilege to work with you. And please contact any members of our staff whenever we may be of assistance. So thank you all very much, and we will see you next month. Bye-bye.